Hello everyone. So finally NEET has happened and I hope अच्छा किया होगा. जैसा भी किया now, just leave it. So we are here to discuss just the answers. अब हो गया paper, don't think much about it. As such, among these 200 questions, 26 questions were of OBGYN. It's a good number. And I would say different pattern, बहुत अच्छे clinical questions थे. And I agree, repeated questions were not much, but the topics were repeated. Like last year, platinum-based chemotherapy was asked. So I think examiners are getting more interested into chemo radio, and not very detailed things were asked. They just want you to know basic. They just want that once you have cleared the MBBS final year, you should know basics about everything. In fact, the commonly encountered things. As such, it was a good paper. So without wasting much time, we'll discuss just the answers, a little detail about it. They are checked, authentic answers. Detailed explanation I'll come up with in 3 to 4 days. Okay, let's start now. Okay. So first, there were almost 4 questions on cancer cervix. Okay, which is very unlikely. Generally, itna on cancer cervix or any cancer was not asked previously. So a lady with necrotic lesion on cervix was diagnosed as cancer cervix. Now it was seen that it is involving the lateral pelvic wall. So what is the stage? Lateral pelvic wall is involved. It is stage 3. Okay. And what will be her treatment? So basically they have asked what is the treatment for stage 3. It is definitely not surgery. Surgery is for stage 2 and above, not chemo. Okay. It is not brachytherapy. It is chemoradiotherapy. Why not brachytherapy? Brachytherapy plus external beam radiotherapy means brachy is apne vagina mein dal diya hai, that source of radiation. So that is also used, but at stage 3, जिसमें lymph nodes are also involved, you need external beam. Okay, and chemo is given in cancer cervix advanced stages because chemo make your tissue very sensitive to radiotherapy. So advanced disease, chemo radio is better. If you are giving radio in early stage disease, then brachytherapy would have been answered, but it's an advanced disease with lymph node involvement. Stage 3 mein lymph node is generally involved, so it is chemo radio. Okay, this is your. So not this, this is your answer. Next. Now again, a patient who had cancer cervix underwent radical surgery. Now they are asking, she has a 14-year-old daughter, what will you do in her? First of all, is cancer cervix genetic? If you study books, in books hereditary is nowhere mentioned as a risk factor. Like hereditary is a very strong risk factor in ovarian cancer, but not in cancer cervix. At some places you might find that rarely genetic correlation could be seen, but not exactly to cancer cervix. It has seen that sometimes genetically you tend to, you don't easily wash out HPV like other ladies. Okay, some genetic inheritance is there, but there is no full proof, any proof of genetic inheritance. So basically, if your mother has cancer cervix, you having cancer cervix risk is very less. Okay, so BRCA testing obviously out. It is for ovarian cancer. Cervical biopsy in a 14-year-old, you will not do a cervical biopsy. She might need screening eventually. If some changes are there, then biopsy. PTEN mutation testing. See, PTEN mutation. PTEN is a tumor suppressor gene seen in Cowden syndrome, which is linked with what? With your basically endometrial cancer. Okay, it is linked with endometrial cancer. Sometimes with ovarian cancer and endometrial cancer. PTEN mutation testing is done when your ovarian cancer is not responding to chemotherapy and you want to give monoclonal antibody, then you see for PTEN mutation, because it will tell you whether it is sensitive to monoclonal antibody or not. It has nothing to do with cancer cervix. So you as such don't need anything to do in this. But vaccination is universally allowed in everybody, majority between 9 to 11 years of age, but can be given up to 25 years. Right? That is the recommendation. So vaccination is given in everyone. Okay, so that is the step which you will do, right? This is the answer. Oh, simple. What is made by neoadjuvant chemotherapy? So they are very interested in knowing whether you know basics of chemo radio or not. Okay, so what is neoadjuvant chemo? Chemo started along with surgery. Chemo started before surgery to decrease extensive lesion. Yes. Adjuvant chemo is you have done the surgery. After surgery, जो residual disease है उसके लिए you are giving chemo. Neoadjuvant means you have given some cycles of chemo before surgery. Why? So that the tumor shrink. It becomes resectable. कई बार tumor is so extensive that surgery becomes very difficult. So you give chemo की कुछ cycles before surgery to shrink the tumor. then you do surgery, and remaining cycles you give afterward. That is neoadjuvant. So chemotherapy started before surgery to decrease extensive lesion. Started with radio, yeah, started after surgery. No, it is not neoadjuvant. Okay, this is very basic. Okay, now fourth question on again cancer. Which statement among the following is true about radiotherapy? Intestinal mucosa is radio-resistant, blood vessels are radio-resistant, effect of radiotherapy on normal tissue and cancer tissue is same. See, radiotherapy acts maximum on those cells which are rapidly dividing. So cancer cells which are rapidly dividing are very radiosensitive and they even cannot heal again. In normal tissue also, the cells which are rapidly dividing, those organs are more sensitive. And the effect is different on normal tissue and cancer tissue. Why? Because cancer tissue cannot heal on itself. There is no normal growth. Normal tissue will heal also. Okay, and it is comparatively less radiosensitive. So this is gone. Intestinal mucosa is very radiosensitive. Okay, in fact, GIT complications are the first earliest complication after radiotherapy. Intestinal mucosa, your bladder mucosa, they are very radiosensitive. Blood vessels are also radiosensitive. The radio-resistant cells are basically like that of your CNS, your neurons, okay, your pulmonary tissue, okay, your heart. So they are relatively radio-resistant, which will show late effects. Okay, so these two options are gone. Now, radiation dose received by a particular organ is is inversely proportional. So, inversely proportional to distance. That is very basic. If your organ is far from the source of that tandem which is giving the radiation dose will be less. It will receive less dose. Exactly, right? So, basically, on common sense only you can answer that obviously the organ which is far will receive the rest dose. Okay, that is why you try to put that tandem as close to the cancer as possible. Right? So, this is your answer. Now, infections was also asked. There are almost 4 to 5 questions on infections, genital infections. What is true about trichomonas? Okay, it cannot be cultured. It can be very well cultured. Okay, it can be very well cultured. Not very commonly used for diagnosis, but it can be cultured. It is not sexually transmitted. It is a sexually transmitted infection. What are the infections which are not sexually transmitted? There are only 2. Your candida and your bacterial vaginosis. They are not sexually transmitted, but it is. On wet smear, cyst of trichomonas seen. Cyst of trichomonas is not identified. There is no cyst in trichomonas. Okay, it's an basically on microscopy you can see the trichomonas with their mobility. Mobile trichomonas can be seen. Cyst is not seen. Cyst is something of an organism which is seen when it is trying to survive in outer environment. Trichomonas cannot survive externally. So cyst is not identified in life cycle of trichomonas. You can see directly on biopsy of urine or cervical smear the motile organisms. You can also see pap smear and it is very diagnostic. Take just the cervical smear, see it in the microscope, you will see moving bacteria. Okay, so this is your answer. Sorry, moving it's not bacteria, it's the parasite. Okay. Now, a lady present with vaginal discharge on examination. On examination, she has a cervical erosion. Okay. So, she has vaginal discharge and cervical. What kit will be given? So, they want you to know the color of kit according to the symptoms. Red kit is for herpetic lesions, right? Yeah. Green is for vaginal discharge, right? Blue is for non-herpetic lesion. Gray is for basically, cervical discharge. When there is cervical discharge, okay, then you give gray. It is clearly saying vaginal discharge with cervical erosion is there, but discharge is not from cervix. Okay, so answer will be, more appropriate answer will be green. Right? A lady with multiple partners present with perineal ulcer, painless. So ulcer is painless. Inguinal lymph node, which are also painless. Diagnosis, very easy question. Chancroid, it's not a painless ulcer. Pain is present in the chancroid. Yes. Syphilis, yes. Painless ulcer, painless lymphadenopathy, right? Granuloma inguinal, definitely painless ulcer, but lymphadenopathy is not there in granuloma inguinal, right? Herpes is painless, very painful. Okay, so your answer is syphilis. Detailed answers we'll discuss after 3 to 4 days, detailed explanation. A patient with MSP is multiple sexual partner present with swelling and difficulty in walking. Examination image has been shown. Something was like that. What is the diagnosis? Very easy. So what is there? near the labia at junction of anterior 2/3 and posterior 1/3. What is there? It is Bartholin gland, right? So Bartholin gland, Bartholin cyst must have been there. Now due to repeated infection, due to multiple sexual partner, it has become Bartholin abscess. So this was your answer. Candida does not present like this. Syphilis and herpetic ulcers, they both present with ulcers, not a lump like this. A patient presented with vaginal discharge, which eventually stopped. Now she has pain. It means now she has developed pelvic inflammatory disease with little intermenstrual bleeding and dysuria. So now it is not vaginitis, it is PID. Causes of PID, gonorrhea and chlamydia are the most common cause. Chlamydia was not there in the option, so answer is gonorrhea. Trichomonas will not present. Trichomonas will characteristically have foul smelling vaginal discharge. Candida will also have curdy vaginal discharge, not intermenstrual bleeding and dysuria especially. Okay, gonorrhea causes urethritis, so dysuria is there. Syphilis will present with ulcers. Okay. A patient undergoing hysteroscopy was seen to have 2 liters of fluid deficit. Questions on hysterolaparoscopy was asked, endoscopy was asked, and there were almost 3 to 4 questions. Okay. So now hysteroscopy, this is a basic thing. Now hysteroscopy was being done, fluid was being used, there is a fluid deficit of 2 liters. So significant fluid deficit, this is significant fluid deficit. So you should have stopped the procedure at 1 liter, right? So what will, in fact you should have become very alert at 1 liter and stopped at 1.5 liters. So now it's a big fluid deficit. What will be the earliest complication? So whenever lot of fluid deficit means lot of fluid has been absorbed by the patient. That is why this deficit is seen. You have ingested fluid, the output is less. So where has that fluid gone? Into the patient's body. What will be happening? The first symptom is fluid overload, pulmonary edema. Pulmonary edema followed by hyponatremia patient will have. Then she will have cerebral edema followed by death. This is the sequence which happens. Okay, acute tubular necrosis, thromboembolism, that doesn't happen that early. First is pulmonary edema. Okay, cerebral edema is also late manifestation. Okay, after pulmonary edema, hyponatremia, then happens cerebral edema. Right? So this is your answer. A patient is posted for hysteroscopy noti. Now they want to ask that what all procedures can be done hysteroscopically. So hysteroscopically you can done procedures obviously with pathologies inside uterus. You are going inside uterus. Outside uterus you cannot do anything. Tubal ligation can you do hysteroscopically? No. There are certain intratubal procedures like Assure which are not called tubal ligation, tubal occlusion they are called. Okay, so they are permanent sterilization methods using Assure, but they are not tubal ligation, they are tubal occlusion procedures which can be done hysteroscopically. Tubal ligation is done laparoscopically. Subserous myomectomy, subserous myoma is located somewhere here. You cannot operate it via hysteroscope. Okay, you can operate only submucous myoma. So this is gone. Polypectomy, yes. Uterine polyps is intracavitary and you can definitely operate it hysteroscopically, right? Cervical polyp, you do not need hysteroscope. Cervical polypectomy can be done directly, right? So this is your answer. A patient advised for laparoscopy. Okay, now they want to ask, laparoscopy has lot of advantages, but one disadvantage is there, and which one is that? Is it more painful? No, it is less painful. The incisions are small, it is less painful, fast recovery is there, so it is gone, it is gone. Blood loss is more or less equivalent. Okay, it's not, I'll not say less blood loss, but more or less equivalent. Electrosurgical complications can very well occur in lapro and they are detected late. Okay, so complications that can occur in open surgery, because since you have a wild field of vision, you can directly identify, but complications especially of burn, electrosurgical burn, are detected late in laparoscopy. So this is the answer. This is the disadvantage of laparoscopy. A 23-year-old patient brought by her mother-in-law, MIL, mother-in-law. So after 6 months of marriage, it has been only 6 months and she is not able to conceive. Of course, she has been brought by mother-in-law only after 6 months. Now, she is menstruating regularly. Her BMI is also normal. Her age is also normal. What will be your next step? You will reassure her? Yes. So, when will you evaluate a patient for infertile? Give her a time of at least 1 year. That's when she'll fall in the category of infertility, and that's when you will start evaluation. Unless there is something in history, like if she has irregular menses, if she has history of surgery to abdomen, if she has history of radiation in which you think ovaries might be affected, or if she has hyperandrogenism, or if there is history of surgery in the husband, then you will start the early evaluation. Then you will not wait for another 6 months. But here everything is normal. Her age, BMI and menstruation is normal. You will wait for another 6 months and then you will evaluate. Okay. Husband semen analysis. Sorry, just pardon my spelling mistakes. I have prepared in a lot of hurry. Husband semen analysis is not needed. HSG and histolapro is not needed yet. Okay. Unless you have significant history of tuberculosis, suppose. Then you will do all those. Okay. Another question on infertility. Patient was given HMG for IVF. Okay. Her USG shows this. What is this? It's a repeat question. So, can you see enlarged ovaries with multiple cysts, big, huge cysts? Is this hyperstimulation of ovary? Now, it cannot be PCOS. PCOS presents with enlarged ovary with small cyst. Small cyst is characteristic. 2 to 10 mm cyst in the periphery is PCOS. It is not. Dermoid cyst is not multiloculated. There is certain solid structure, ground glass appearance is there. Okay. It can be theca lutein cyst. Theca lutein cyst, which is present in molar, also has this cartwheel appearance. And it is very difficult to differentiate just seeing the ultrasound. How do you differentiate both of them? In history, they have clearly given that she is on IVF treatment, so she is not a molar pregnancy, she is not theca lutein cyst, she is OHSS. Okay. Okay. A patient of PA is primary amenorrhea. A patient of primary amenorrhea presents with cyclical pain and suprapubic lump. So, cyclical pain, suprapubic lump, most likely it is Mullerian anomaly. Okay. Now, on per rectal examination, fullness was felt in whole vaginal length. Very important line. Fullness was felt in whole of the vaginal length, whole of the length where you think vagina would have been there. So, what is the diagnosis? All of them are causes of cryptomenorrhea. It's a cause of cryptomenorrhea. Okay. She does not having menses. Suprapubic lump is basically the uterus. Cyclical pain is there. So, all of them will cause cryptomenorrhea. But whole vaginal length has fullness. Cervical agenesis, vagina is not there. There will be no fullness in vagina. Okay. Cervix is agenetic. Okay. So, this is gone. Upper vaginal septum also, in whole of the vagina, blood will not be able to collect. Why there is fullness? Because there is blood getting collected in whole of the vagina. Imperforate hymen, yes. So, imperforate hymen, this is your uterus, okay, and this is your vagina. Somewhere here is the imperforate hymen. That is why blood is filled in the vagina and you are feeling fullness during your per rectal examination. Okay, so this is your answer. Complete vaginal agenesis, you will not feel any fullness. Okay, vagina is agenetic. Okay, so this is your answer, imperforate hymen. A girl of primary amenorrhea with no breast, no pubic axillary hair, bilateral inguinal mass is present. Ultrasound, no uterus, vagina and ovaries are also diagnosed. I don't like this question much. It's a very confusing question. Look, the answer is very clear, but presentation what they have given is just to confuse the students. It was not needed to give such a confusing and rare presentation. Let's go one by one. No, she doesn't, primary amenorrhea, she has no secondary sexual characters, not at all. So you will think of first, most common, Turner's. But why is it not Turner? Turner will not have bilateral inguinal masses. Bilateral inguinal masses are what? Obviously it is testis. Undescended testis are there. Turner may, there is ovaries are present, but they are dysgenetic. They are saying ovaries are not there, inguinal masses are there, so it cannot be Turner. Turner will not have testis. Then PCOS. Okay, so now in PCOS, definitely this is not the finding. They have secondary amenorrhea with breast and pubic hair and developed secondary sexual character. So this is also gone. Hypergonadotropic hypogonadism means Turner is itself a cause of hypergonadotropic hypogonadism, means gonadal agenesis. Your gonads are not working, gonadal agenesis or premature ovarian failure. These are the two causes. Gonads are not working, that is why your FSH, LH are higher, hypergonadotropic hypogonadism is occurring. So, gonadal dysgenesis means you have ovaries, but now they are dysgenetic, either due to Turner or pure gonadal dysgenesis. Turner mosaic is there. So, you will not have secondary sexual characters, but bilateral inguinal masses clearly indicate that patient has testis. She is XY. Okay, so which of them is XY? They all are XX. Turner mosaic can be X0, XX, can also be XX or XY, Turner mosaic. But then also there will be dysgenetic gonads only. The person will not have, testis. Okay, testis will be there in XY individual, which is complete androgen insensitivity. Now what was confusing? Everything is fitting well. Inguinal masses, no uterus, no vagina, no ovaries, no pubic axillary hair. With no breast. Breast is there in complete androgen insensitivity. because peripheral conversion of androgen, peripheral androgen is converted to estrogen, which leads to breast development. In fact, that female adiposity is also there in AIS. That is why the person looks like a female. So here also physiology was that of a female. That clearly question mentioned that physiologically she looks female. So adiposity of females and breast of females is there in complete AIS. But sometimes in AIS, breast development might be delayed. When patient present to you, you might not find breast. Okay, so this can be presentation but not a common one. Okay, so this is your answer. Okay, all other just do not fit in here except breast tissue. The answer is this. So breast can be developed late in AIS, but common presentation is breast development with no pubic and axillary hair, right? This is the answer. Now OBS question. So 35-week pregnant woman delivered twins last time. What is paragravida? Very easy. So last time she had twin. So she has been, gravida means how many times she has been pregnant. So she is pregnant for the second time, not the third time, right? Pregnant for the second time. Last time she was pregnant, but she had twins. Second time, this time again she is pregnant. Para means how many times she has delivered. So gravida means how many times she has been pregnant. Para means how many times she has been delivered. How many times she has been delivered? She had twin. She has delivered once. No doubt in that one delivery, 2 babies were there, but delivery was one. There were not 2 deliveries. There was 1 delivery, 1 vaginal delivery, 1 labor, and babies were 2. So she is G2 para 1 live 2. Okay. So what is your answer? G2 P1. Right. It's not para 2. She has not delivered twice. She has delivered once. Okay. So G2 P1 is your answer. A patient 32-week pregnant present with over distended abdomen. Okay. And symphysiofundal height was also 41 weeks. So over distended uterus. Fetal parts not easily felt but not tense. Important. FHR also not easily audible. So difficult in feeling parts and fetal heart. Vitals normal. What is it? Is very clear cut polyhydramnios. Why not fetal and maternal ascites? Why fetal maternal ascites? Vitals are normal. No medical history has been mentioned. So this cannot be the case. Abruption. Why? Because they have clearly said it is not tense. That is why they have mentioned not tense to exclude abruption. Okay. So exclude abruption. Now IUGR, no. Symphysiofundalitis high. So this is definitely excluded. So this is polyhydramnios. A 36-week 6 days patient with transverse lie. Now this is a repeat question. Okay. Everything else is normal. So there was fluid was normal, placenta was normal. Previous to vaginal delivery. What will be the next step? It's 36 weeks 6 days. What will you do? If it's transverse or if it is breech. So no contraindication for vaginal delivery in this patient was given. Definitely you can try for vaginal, but you cannot try for vaginal in transverse. What will you do first? You will do external cephalic version. She is just at 37, right? So definitely after 36 weeks, you can try for external cephalic version. In case the version has been failed, you will go for LSCS, okay? That too at 30, that too not write immediate LSCS you will not do. You will wait till 39 weeks or unless she goes in labor, right? So LSCS is not an option right now. Expected management, no. You will do something. You will not let her be in transverse lie. You will do external cephalic version. Induction of labor you will not do in transverse lie. You cannot deliver transverse lie. First you will do external cephalic version. Okay, this is your answer. Even if it would have been breech, then also. A patient of infertility of 3 years has 6 weeks amenorrhea now. Presentation with spotting, okay, on ultrasound adnexal mass with fetal pulse. So it's an ectopic pregnancy, but no cardiac activity. Sorry, no cardiac activity. Size, I said, pardon my spellings right now. Size of sac was 2.8 centimeter and HCG was mildly high. What will you do? So size of the sac is less than 5 centimeter. Cardiac activity absent. HCG is less than 5,000. These are the ranges, okay, for starting the surgery. So definitely this patient falls in a group of medical management. Okay, so you will go for medical management first. Besides, she has a history of infertility. If she has an history of infertility, you will not straight away go for self-injectomy. So she falls in the category of medical management. What will you give? Oral methotrexate? Methotrexate is not given oral. Single dose self-injectomy is not done. Right? She does not need surgery. She is not having any acute symptoms. Vitals were stable. HCG is less. You don't need to do that. Single dose methotrexate or multiple dose? I have told multiple times in my class, multiple dose methotrexate with leucovorin is treatment of molar pregnancy. It is not treatment of ectopic. Ectopic need only single dose. Then monitoring. So give it at day 0, give methotrexate. Do, HCG levels at day 4 and day 7. Okay, if the fall, why not compare between day 0 to 4? You cannot compare HCG level between day 0 and 4 because once you give methotrexate, they tend to rise in between. So you compare day 4 to day 7 methotrexate levels. If there has been fall in more than 15%, now it means your injection has worked. So you will just monitor it. You don't need any more dose. In case it has not fallen, then you might need to go for surgery. So single dose methotrexate is the treatment for ectopic, not multiple dose. Multiple dose with leucovorin is treatment for molar pregnancy. Okay. Yeah. Now, a lady with asthma in labor, important. In fact, everything is important right now what we are discussing. What will you not use in third stage of labor? We have discussed in our lectures. In asthma patient, prostaglandins, you have to be very alert while using prostaglandins. Some prostaglandins are absolutely safe, like meso. Meso is absolutely safe. You can use it. Dinoprostol, use but with very cautiousness. Okay, you have to be very alert while using dinoprostol. So this is gone. You cannot use carboprost. You cannot use methergin. Absolutely contraindicated. Okay, so this is your answer. Oxytocin, you can use it. A patient 34 weeks pregnant feel dizzy on lying down. It is again a repeat question. Feel better on turning to left side. What is this? It is IVC compression. Whenever patient feels dizzy on straight lying down, IVC gets compressed. The venous return to blood is reduced and she starts feeling dizzy. As she turns on the left side, the compression on the IVC is relieved. Okay, it's not postural hypotension. I have not received what are C and D, but this is your answer. Okay, now management was asked based on partogram. Very good question. So this was partogram. I know what was there, so I have got a clear picture of what the partogram was look like. So they showed that heart rate was from 140 something like that up till 120. So heart rate was normal. That was told to me. Fluid was clear. Molding was ++, 2+. Now they said that whatever time she came at, after 4, then after 8, her findings were from here to here. So they crossed the alert line, but it did not reach the action line. It has crossed the alert line. I remember that. So, and descent of fetal head was something like from 4 to 3. Yeah. So it was 3/5. This was the descent of fetal head. Contractions were good. As told to me, contractions were 4 contractions, good intensity. It was black, clearly like that. You know? So good contractions. She was on oxytocin, something international units per minute. Yeah. And then pulse and vitals were totally normal all through the procedure. And urine protein acetones were also nil. So that was the picture. Now, what will you focus on? So definitely alert line has been crossed. You have to be alert. It was almost near to action line. So that is why they want to know what action will you take. You are almost reaching the action line. She is not dilating at a good speed. What will you do? So what will be the deciding parameter? Everything is clear. Fetal heart is clear. So as such, not much complications are there in this pregnancy. The cervix has fully dilated. Okay, so what options you have? You have instrumental delivery, you have LSCS, you can wait. Okay, but since you are reaching the action line, you cannot wait more. Okay. Now the important was the descent of head. Descent of head was from 4/5 to at the last here it was 3/5, right? It was 3/5. So descent of head is plotted as number of parts palpable per abdomen. This is not 3+. It is not 3+. You are not doing it per vagina. It is 3/5. Descent of head is being plotted how many parts you are able to feel per abdomen. 3/5 means it has not even engaged. 1/5 when head is here, 1/5. Okay, only one part of fetal head is being felt per abdomen, then means it is engaged. It has crossed the ischial spine. 3/5 means it is way above the ischial spine. It is not engaged. Now, this was an important point here. Let's go to the option. Vacuum. In such a height, can you apply vacuum? Outlet forceps. It's not at outlet. It is 3/5. It's not engaged. You cannot apply vacuum. Head has to be engaged. You cannot apply forceps. Oxytocin is not needed. Contractions were good. You will do LSCS just because head is very high. Okay, and molding was plus, so most likely CPT. Yeah. Now, next question. A patient in 2nd month of her pregnancy with anemia, hemoglobin 9 g/%. What is true about starting the anemia? Again, this was the question. It didn't seem very appropriate to me. So the options were, so she is in 2nd month, or she might be in 8th week of her pregnancy. 8th week she must be having. What is true about starting iron? 8 to 10 weeks, 10 to 14 weeks, Next was 14 weeks onward, 20 weeks onwards. Onwards was not written here. So it was not clear whether they are saying that till 8 to 10 weeks you have to give iron, till 10 to 14 weeks you have to give iron, because here onwards was mentioned. Okay, it means it is very clear that they want to tell you that after 14 weeks you will start, after 20 weeks you will start, but here not onwards was not mentioned. So I don't know whether they forget to mention the onward, whether they wanted to ask that by start the iron but continue till 8 to 10 weeks. Okay, seeing the scenario that onwards was not written in above two options, actually what you have to do is you have to start the iron at 4th month, which is almost 16 weeks. So you have to start it at 16 weeks and continue it till 180 days, even in the postpartum. So this was gone. If the examiner wants to say that what is true about starting iron 8 to 10 weeks, means for 8 to 10 weeks you have to give 10 to 14 weeks, then these are not the options. It has to be given for 180 days total. Okay, yes, you have to start at 14 weeks. 14 weeks onwards you start. Now imagine if the onwards was here, then also this was not the answer. You do not give it at 8 to 10 weeks, you do not start at 10 to 14, you start even at 14 to 16, start at 4th month. So which is more appropriate, could have been 16 weeks. So closer to it is 14 weeks onwards you will start the iron. Okay, so this was the answer, not 20 weeks also. That will be too late. Okay, this is according to Anemia Mukt Bharat, because last time the question on Anemia Mukt Bharat was asked. Okay, so read that very clearly. A patient delivered baby at 31 weeks. Now 2 questions were there on the perinatal infections. So baby was preterm with rash and bilateral cataract. Many other things were there, but when they are saying rash and when they are saying cataract and yeah, so and I think there was heart defect also, and there was heart defect also. It is characteristically rubella. Okay, so cataract with heart defect and preterm is rubella. So there are certain things which you have to notice in perinatal infections to know what it is. Okay, so varicella can also have such presentation. Basically it is, but chorioretinitis more. And herpes also, herpes has organomegalis. Okay, and syphilis also does not present like that. It is Clutton joints and abnormal bone development. Rubella has cataract and heart defects, PDA especially. Similarly, another question said rash, thrombocytopenia, hepatosplenomegaly and splenomegaly, sensory neural hearing test. So hearing test failed, and periventricular calcification. Now this was easier. Why? Because whenever you think of in perinatal infection, whenever you read calcification, think of 2 things. 2 things have calcification: CMV and toxo. CMV and toxo have calcification. Toxo mein there is intraventricular calcification. Periventricular calcification is in CMV. Also, sensory neural hearing loss is feature of CMV. Hepatosplenomegaly and thrombocytopenia is a feature of CMV. So this is your answer. Parvovirus basically presents with anemia, autoimmune anemia, and not also perinatal herpes. Okay, so this was the answer. So all the 26 questions I have covered. I hope the answers were clear to you. You can blindly rely on the answers. They are very authentic answers, very nicely checked from the reference, and the detailed explanation I'll come up in 3 to 4 days. Now whatever you have fared, don't worry. Jo ho gaya ho gaya. कहते हैं ना that something which has not killed me will make me stronger. If you will get good result, very good. If not, you would have learned something, right? So just now relax. You have worked a lot, and have a good and happy Holi. Bye bye.